Good morning to you once again. Priscilla, Regina and Aloga here. We still continue to look at medical care in Uganda as we are marking the big 6-0. What is the state of the health sector and what challenges have been faced by the health sector 60 years later? We get to look at the health system in Uganda having been criticized for being inequitable, with the poor receiving less services than needed and the rich receiving more than needed. And we've seen so many of those happening around, especially most recently when we did have the late Speaker of Parliament being flown out of the country to receive medical attention. You have seen public servants being flown out of the country to receive attention to their state of health at the time, and the poor don't have that privilege, and yet, quote unquote, the services seem to be here. Qualitative evidence has also shown distance to government health facilities is a barrier, both to the facility being too far to travel to, and also the economic opportunity costs that are associated with the travel from one's community to that health facility. We do have Dr. Herbert Luswata, who's the Secretary General with the Uganda Medical Association, joining me for this conversation to paint a better picture for us of what the medical sector looks like right now as we make the big 6-0. Good morning to you, Doctor.
Good morning.
I want to start by asking you, having been in this field for 10 years, what has your experience been? What would you say, these are the best things about our medical sector, these are the challenges that our medical sector is faced with?
Yes, good morning, viewers. Herbert Luswata, Secretary General, Uganda Medical Association. Thank you for inviting me today. Let me start with the good. You know, there is always something good that is happening despite the negatives we're having around. I think from the time of independence, since we are now looking at the 60 years after independence, by the time we got independence, we had Mulago, which was started way back by our colonialists. I think that was in 1913. So by 1962, at the time of independence, then we got new Mulago. Initially we had old Mulago, then we got a new Mulago. By that time, I think it was still the Queen who was the head of state of Uganda. I'm going through the infrastructure first. Then we got Mulago, Uganda Cancer Institute, around 1976. These are achievements we have been getting, and I think around this time, President Obote was the president of the time. Then we have Uganda Heart Institute. This was opened in 1988. I think by this time we had the NRM government in power. So by and large, these have been a good achievement. However, during that time, at the beginning of independence, many things were quite good despite what is happening right now. On the side of government, I think we had a very good budget for health in the health sector. At that time, we used to have enough drugs actually in the hospital, or people could go in the hospital. And when they said this is a government hospital and the services are free, they were indeed free. We could, doctors at that time or fathers could prescribe drugs, and patients could receive these drugs from the window, from the pharmacy, free of charge. Patients would get food. They could get lunch and supper in the hospital.
Really?
Yes.
This is news.
Yes,
because that has become a whole entire business in the public, hospitals right now.
For the food vendors.
Yeah.
Yeah, and they used to get good food. They even used to have a timetable. They could have chicken and goat's meat.
Dr. Herbert,
it used to happen, and actually it is still happening.
This is the same Uganda we're talking about today.
Yes, I'm telling you about Uganda at the beginning of independence, when the whites had just left us, the good state they left us in. It is still happening today. Mulago, they still offer food to the patients, despite the fact only that it is not the same type of food they used to have before. At least I know about Mulago and Kawempe National Referral Hospital, and then Chirudu, At least they have kept this culture.
They still offer it free?
Yeah, to all patients who come to the hospital.
Okay.
And that is very good. Many regional referral hospitals, I think, have not been able to do this because of a small budget, and that is unfortunate. Then on the side of health workers, that time when you could qualify as a doctor or even a nurse from the university, a van would be just there waiting for you to take you with your, your bags and mattresses. They could take you to a house. We could have even servants in the house, people to help you in the home. We would be very comfortable. And the salaries that time were really good. The money, when you listen to the figures, when they tell you it looks small, but that money held a lot of value at that time. And actually, health workers used to command a lot of respect. The senior consultants that time were entitled to, you have a house. In addition to house, you must have a car, a government car with red number plates, and a driver. And these things are actually still in the laws of this country, except that they are no longer providing these things, much as we have tried to advocate. And yes, we need them, and our consultants need to have these things. Then still to the public, today we talk about prevention. We tell people, you have to do this to prevent yourself from diseases and all that. Nowadays, the messages about prevention of diseases, they are there, but they are not good enough. Even with the outbreak which is happening, we feel that in the public, the information is still very deficient. The government is not putting in a lot of effort to ensure that the public is well sensitized about these things and to be protected. And it is a problem to us, the health workers, because we cannot do that without the support of government. Yes. Okay.
Let's talk about the medical sector in reference to some of the diseases that have actually had this country almost to the brink. One of them being HIV/AIDS. Back in the 80s and in the 90s, it swept a lot of people and it took on so many. But again, you get to have the medical sector having been present at that time, and they influenced what happened. Could you give us a reflection of that particular time of HIV/AIDS when it was at the epitome?
It was really bad. By the time we registered the first case of HIV in Uganda, we didn't have any treatment or non-treatment for HIV, and it became a very big risk to us as health workers. Because when you need to operate like on patients, usually there are risks like needle stitch injuries. Even in the process of care of the patients, actually during that time, even the protective equipment like gloves, we used to do a lot of work with our own hands. You could even touch blood, because at that time there was no, apart from the HIV, there was no any other big threat that was around. And a number of people who are working in hospitals, including cleaners, actually contracted HIV because they were using their hands and were not protected. A number of doctors got HIV in the process of the operations when mistakes could happen and they get needle stitch, injuries. HIV patients used to get HIV psychosis. And in that state, some of them, they could come too bad and they wish to just infect everyone or anyone, and some health workers actually suffered this. Some would just prick themselves and then prick any person next to them, and some of these people were health workers. So it was really very bad, and we lost people during that time. However, we are happy that now we have the drugs, and actually Uganda is one of the countries which is manufacturing ARVs in East Africa. We are manufacturing for Uganda and even exporting to other countries. I think that is a very good achievement for the NRM government. In addition to others, also the number of hospitals today have increased. I was reading a record which was from the Ministry of Presidency of October 2021, and it was talking about referral hospitals which have increased to 181. And health center 4s which have increased to 222, health center 3s are 1,500, You know, when you have infrastructure around, and when it comes to combating disease, it becomes a bit easier because you bring services closer to the people.
Okay, now let's talk about the challenges that have caused the Uganda Medical Association to order strikes, so many of them in the last 4 years than I have ever heard of in my entire lifetime. What are some of those challenges that you as the service providers in the health sector are still grappling with and government is still not heeding attention to?
One of the biggest monster was the low pay, because for a long period of time our GDP as a country kept on growing. We kept on getting inflation and prices were going very high for commodities, and we used to see salary increments for people in different sectors, but it was not happening for health for a very long time. It was too bad to the extent that some health workers could sort other ways of looking for extra pay, and that's why they have been running around to many facilities, because they're trying to make ends meet. And this affected the public because they did not have the health workers committed to them, because they're not concentrating and the services were not good. However, we are happy that on the issue of the salary increment, at least government has done something. It is not the best. There are some cadres which we think we really appreciate the government. They have done their best, like for the senior consultants and the consultants. But we still need more push for the medical officers and the specialists. At least they have done something. We hope maybe they will also sort the discrepancies we have around, because when they give salary increments, the margin between the lowest cadre medical officer and the specialist, the difference in pay is very minimal, and yet when it comes to qualifications, if I'm a gynecologist, I'm a specialist, I have 8 years of education. The medical officer has only 6. But the difference is really very small. So we hope government will be able to sort that, so that the specialists can be, motivated. The other issue about the strikes has been around risk allowances, because whenever these epidemics come, the people who are most at risk, it is on record, are health workers. Because you go in to manage epidemics like COVID, by the time it came, you didn't have any treatment. You go in knowing that if I get COVID, I can die like any other person. Ebola with a very high fatality rate, So I don't know, we are still struggling so much with the government to accept and to understand that paying a risk allowance and compensating health workers who die, it is something that is very crucial and very important for the mental health of the health workers. You know, when...
So let me ask, according to the association, at what point is this risk allowance supposed to be remitted to the health worker?
When we start working in the units where patients are being admitted, the ones who are sick because of these epidemics, there are people who are allocated to work in those areas. Then we have people allocated to work at emergency areas to receive patients. Those are, because the emergency areas, that's where you do triage and you isolate those ones who are sick. These ones are not sick. The ones who are sick, you should go to a treatment unit. So in the treatment units and the emergencies or isolation areas, that's where the points where you have health workers who are very high at risk of getting these epidemics. And it is the same thing even right now. At emergency base, at all government hospitals, everyone is at risk and everyone needs the PPEs. Unfortunately, the government knows, actually. They are aware, because people in the Ministry of Health are technical people, they are doctors. They know that people deserve risk allowances. Even World Health Organization knows that people are supposed to get risk allowances. And even the compensation when someone dies in the line of duty. But the government is so sluggish on embracing some of those things. And then you realize that they're embracing other things which are not, really very important. We got a lot of donations from many countries during the time of COVID. People contributed money here. Even the poor could contribute 500 Ugandan shillings. But the unfortunate bit is that up to now we still have health workers who are demanding government risk allowances.
Still, you have brought out the donation part. And according to what was being shared to the country during COVID-19, the donations were coming through, and they were really focused on empowering the health sector to deal with COVID-19 at the time. So the assumption is that post-COVID-19, the health sector has more equipment. You do have more PPU, ware that is readily available for any other outbreak. But then Ebola comes, and it seems to show us that it's not the reality on ground. If you medical workers are still calling out for government to give you the PPU, to give you the risk allowance and all these other provisions to deal with outbreaks such as Ebola.
It is a problem, and sometimes we think it is intentional by government to frustrate health workers. And this is very bad. So actually, some people will tell you, there are even doctors in, with power, they're in administration, they will tell you that we shall never pay that risk allowance. We shall never compensate anyone. You go and work if you want to work. If you die, you die. We shall not take care of your family. If you're a doctor and someone is talking to you like that, because Ebola came, how many days are we in Ebola? And health workers are actually dying. But you imagine you die and you didn't sign anywhere that after my death, my little boy of 3 years and maybe my wife, the government has a plan that maybe they will take care of them in such and such a way. You just leave them there like that. The children will drop out of school, the family, and it's
especially for the doctor who from Tanzania. That was really absurd. A nationality that is not yours. Some care should be attended, some attention should be given to that particular case.
Yeah, and what is very funny is that when that doctor was providing services in Mubende, he was not being paid a single coin.
Really?
He was giving a free service. And yet we actually have a directive from the president of Uganda that every doctor who's just super specializing and pursuing their masters, they should be paid at least an allowance, because almost all doctors who are pursuing their masters, they are providing medical services in the government hospitals. But what Ministry of Health did is that they are giving like 60% of the master students these allowances. But SHOs, master students from KIU, from Zambia, are not actually receiving these allowances, and yet they provide services in the government hospital. He died from Mubende Private Hospital. He was providing services to Ugandans, but he was not receiving this allowance. So we had a meeting with the PS, or Minister of Health, and we pleaded with her that surely these people are providing services in the government hospitals. Let us follow the presidential directive, and we also get them these allowances. And then she promised us that she would talk to the directors of the different regional referral hospitals to get actual information. If these people are there and doing the work, then they will start getting these allowances. I think now she has the evidence, because the doctor died from Mubende and he was from a private university.
The same compensation you cried out for the the health workers who lost their lives in the fight against COVID-19, has that compensation been extended to their families?
No. What we got was a promise from the president of Uganda when he said that at least he would support like 1 or 2 of the children of the deceased and maybe pay for them school fees up to university level. But up to now, the unfortunate bit is that no name of any of these children has ever been submitted to State House to be supported. He also promised that, actually directed the Prime Minister that there should be a committee kind of to ensure that these families are compensated. By law, when you are an employee and you die in the line of duty, the law says that they get the salary, the current salary you've been getting, and then they multiply it by 60. This money is supposed to be given to your family so that they can maybe use it as a capital to find where to start from and have their life, continue. We got more than 50. These are doctors, nurses, and the pharmacists. None of these families has ever received this money. We get phone calls from actually members from some of these families who are requesting for some financial support. And how much money do we have as Uganda Medical Association? We cannot afford. And this is a mandate of government.
You're not a financial institution in the first place.
No, and this is a mandate of government, you know, by law. You know, when you still have such a bad history, then we call it even a bad history on the side of government, that you don't compensate for people's lives when they are risking themselves, you don't want to pay risk allowances. When an outbreak like Ebola comes around, some people refuse to work. Not that they are not professional, because when we are studying, we are trained in such a way that patients at all the time should be our first priority. It doesn't matter whether it is COVID or Ebola, our patients should be our first priority. Anything else, including our families, come second, you can imagine. It is groomed in us. However, that one becomes easier if the other party is also doing their part. If government is paying risk allowances, they are willing to know, to compensate. They are giving you the protective equipment. But now when the other party is defaulting on what they can do, the law also allows us as health workers to distance ourselves from work. When you see that there is too much risk for your life and you think it is not really worth for you to go, the law also allows us to retract our labor. And the fact is, some health workers have actually refused to work on Ebola patients, and that is catastrophic. Because it means that if Ebola becomes a big issue in this country and you still have, you know, that mindset in health workers running away because of what you've said as a government, not paying, not being committed to what you're supposed to, it is a big problem. When you get very many patients and the forces you have are not ready to work, it means you may end up losing. Many people become sick. I was listening to audios of some of our patients who were in Fort Portal. At first, actually, I thought it was a lie. You could get recordings of people saying, we have spent 8 hours, we have not eaten, we have spent 8 hours, no one has attended to us. Until I called myself and talked to one of the people who was in the unit. And he told me, it has been true. I was almost dying. The fortunate bit is that by the time I called, it was like at least after, maybe when they listened to the recording, maybe after some noise, some attention was given, you know, to them. There was a very bad recording of a patient who was saying he was dilated 32 times and the feces are about to reach their heads and they have not received any care. It was very, very disturbing.
Okay,
but we are happy.
Dr. Luswata, where do we go from here? In conclusion? In
conclusion, I think to our health workers, the forces on ground who are fighting Ebola, we know our government has its shortfalls, and we understand, but we encourage them, those ones who are there and who have been strong enough despite everything, to continue and serve and treat Ugandans and our colleagues. We thank them so much and we urge them to continue. We shall do our part, which is advocacy. We shall continue pinning government to ensure that they pay these risk allowances and take compensation very seriously. That one we shall do. And then to government, let us be, you know, let us be more serious. Okay. You know, the days are very many since Ebola came here. People have not yet signed for risk allowances. No one has received the risk allowances. People are already dying. There is no compensation plan for these health workers. It is demoralizing. They will keep running away, and that is not good for them. And then to the public, to Ugandans, we know Ebola is here. As health workers, we shall do our best. Actually, we are mobilizing to see if we can get doctors who have worked in Ebola treatment units in West Africa, because they have more experience. Some of them have already became sick, and by God's grace they improved from Ebola, so they have higher chances of fighting the disease. We want to get these people and submit the names to Ministry of Health so that they can be deployed and work under good terms. We shall do our part as health workers, as long as government also do their part. All
right. Thank you so much, Dr. Luswata, from the Uganda Medical Association. And their commitment is, as always, and we have always evidenced it, that they put the patient's life first above anything else. Now, that is service above self, for which we thank every single medical worker that has pushed through the thin and the thick of the challenges that you face to ensure that Uganda gets to have quality medical services delivered to the Ugandans. We take a short breather. We return with our Kickstarter, in which we're going to have a reflection on the Army 60 years down the road.